good afternoon, and perhaps good morning or good evening, depending on where and when you are viewing this presentation. My name is Voigt. I'm a physician and specialist in pulmonary and critical care medicine and in palliative medicine at Memorial Sloan Kettering Cancer Center, where I chair the Ethics Committee. Thank you for joining the first public webinar organized by the Empire State Bioethics Consortium in 2021. I am delighted to welcome you to our discussion. I would like to remind the viewers and listeners that I am speaking today only on behalf of myself and not as a representative of MSK. Likewise, members of the panel will be expressing their own opinions and observations, not the viewpoint of their institutions. I hope that you will find some values in our collective insights. In March of 2020, at the beginning of the COVID-19 pandemic in New York City, several bioethicists, clinicians, lawyers, and members of a few healthcare organizations were witnessing the most jarring healthcare crisis of our lifetime. We felt alone, scared, and overwhelmed. A group of us met every week and grew larger into what is now known as the Empire State Bioethics Consortium, an incorporated not-for-profit membership organization of scholars, researchers, and practitioners dedicated to addressing ethical issues and inequities in healthcare across New York State. Feel free to check our website at www.empirestatebioethics.org for more information. Last year, in the summer, we organized several webinars in collaboration with the School of Professional Studies at Columbia University. These webinars are available on YouTube for your viewing pleasure. We hope that the consortium will serve as a repository of knowledge that is widely shared and discussed, and that it offers you and us practical solutions to the ethical quandaries that our communities have faced, are facing today, and may continue to face in the future. A parallel goal of the consortium is inclusivity. As we strive to make the voice of bioethics heard in New York State, we need that voice to reflect the full range of diversity that exists in New York. If you work in bioethics, please send an email to Ms. Claire Murray at Murray, MURRAYC @mskcc.org. Please provide your email address and a short description of your work, and we will add you to our expanding group. On behalf of the members of the Empire State Bioethics Consortium, I would like to express my gratitude to the program events and AV teams at Columbia University and to Professor Johanna from Albany Medical College for making today's program possible. Now, allow me to introduce Dr. Jennifer Breznay, a member of the Empire State Bioethics Consortium and an attending physician with training in geriatrics and in bioethics from Maimonides Medical Center, who will be moderating today's discussion. Dr. Breznay.
Thanks, Louis. It's really my pleasure to moderate this panel. And it's the first opportunity that we get together as a group for the Empire State Bioethics Consortium to provide this kind of forum. As hopefully you're joining us, we'll be talking about why some hospital employees hesitate to get vaccinated against COVID, and exploring what we should think of our response through a bioethical lens, how we might do that. So we've organized a group of really outstanding, diverse, and Louis mentioned inclusivity as a primary goal. These panelists each represent a unique perspective on the topic, and we'll be encouraging people to participate through the chat, which is on the right side of the screen as well. And we will hopefully solicit questions throughout the presentations of the panelists and spend a large part of the end of the session talking with you through the chat and to our panelists about your questions and comments. So brief introductions before we get to the panelists' comments. I want to introduce Johanna Crane. She's a medical anthropologist and is on faculty in bioethics at Albany Medical College. Welcome, Johanna. Cara Simpson is the director of social work at Jacobi Medical Center at their behavioral health services. And she's a member of Jacobi's Bioethics Consult Service. She's also in private practice as a psychotherapist. And Ashley Stewart is the supervising nurse of the COVID vaccine rollout to all hospital employees at Carthage Area Hospital in upstate New York. She was in charge of the infection prevention coordination effort there. And then finally, David Hoffman will be joining us. He's an attorney affiliated with several hospital systems in upstate New York and is also a bioethicist and lecturer at Columbia University. So we'll be joining these panelists serially, and we'll get started with Johanna Crane. As I mentioned, Johanna is a medical anthropologist with a lot of focus in her work on vaccine hesitancy, and we'll let her tell you more about her thoughts on this issue of the healthcare worker and hesitancy.
Thanks, Jenny. It's great to be here. Thanks, everyone, for tuning in. So yeah, just to introduce myself briefly, as Jenny said, I'm a medical anthropologist. I'm at the Alden March Bioethics Institute at Albany Medical College. And the research, most of my research has to do with health and inequalities in some way, shape, or form. And the work I'm currently involved in is looking at the COVID vaccine rollout at federally qualified health centers. So actually, if the slides are going to come up, yeah, maybe I'll speak to those. So the study that I'll talk a little bit about today is called COVID Vax, the Vaccine Access at Community Clinics study. And it's a collaboration with colleagues at the Hastings Center in Garrison, New York, and also at SUNY Upstate in Syracuse. And it's a small rapid response qualitative study where we're interviewing providers at 2 federally qualified health center networks, one in Tennessee and one in New York State, about vaccine access and hesitancy among their patients. The study itself is not specifically of healthcare worker hesitancy, but this topic did come up periodically, and so I'm going to be sharing some of those quotes during my remarks. But basically what my role here is on this panel to talk about today is the following. Basically, I'll provide a basic definition of what vaccine hesitancy is. I'll talk a little bit about the landscape of COVID-19 vaccination hesitancy generally and specifically among healthcare workers. And then I'll wrap up with some suggestions for respectful strategies for responding. Next slide, please. Okay, so the SAGE Working Group on Vaccine Hesitancy defines it as a delay in acceptance or refusal of vaccination despite the availability of vaccination services. Vaccine hesitancy is a global phenomenon. It's not something that's limited to the US. It exists worldwide and was on the rise prior to the COVID pandemic. I think really importantly for this conversation today and just in general is to note that vaccine hesitancy is not quote unquote anti-vax, nor is it anti-science. And that sometimes gets conflated or confused in the media. What culturally sensitive research from anthropology and sociology suggests is that vaccine hesitancy is often about things like problems related to risk, trustworthiness, and doubt. It's about managing contexts of uncertainty, which we certainly see today. And far from being anti-science, it's about an effort to talk back to science about unaddressed needs and concerns. And I'm specifically borrowing some language here from Heidi Larson, who's an anthropologist who runs the Vaccine Confidence Project, and Ruha Benjamin, who's a sociologist at Princeton, who has written more broadly about related issues. Next slide, please. So which groups are most likely to be COVID-19 vaccine hesitant? This is a graph from the Kaiser Family Foundation. I'm going to be showing a bunch of their data. First, before I go through the chart itself, I'll just say that COVID vaccine hesitancy brings with it a number of issues that make it even, I think, more complicated than the more general hesitancy that we saw before. And so, of course, we know those issues are that the vaccines are extremely new. Some of them are using new technology, the mRNA technology. They were developed more rapidly than we expected, and in a highly polarized political environment. So for all those reasons, public confidence in these vaccines is just more complicated. This chart is from just prior to the beginning of the vaccine rollout, so December 2020. On the cusp of that, there were about, according to Kaiser, 27% of the total population and 29% of healthcare workers who felt themselves to be vaccine hesitant, either said they would either probably not get it or definitely not get it. More recently, Kaiser Family Foundation and Washington Post survey done in March found that frontline healthcare workers, about 12% were undecided about getting vaccinated and 18% were opposed. And those numbers were a little lower among hospital workers, 8% undecided and 12% opposed. Again, that's up data from March. So this is it's a little bit of a shifting terrain, but regardless, there's a significant number of people who are hesitant and a significant number of healthcare workers who are hesitant. Next slide, please. Thank you. The good news is that there's good evidence that hesitancy overall in the general population is decreasing. And this graph represents hesitancy generally. It's not specific to healthcare workers. So, but if you follow the light blue parts of the graph, you can see as it moves up the graph from December 2020 at the bottom to June 2021 currently, the number of people who are saying they want to wait and see has been decreasing. This is really what a lot of people refer to as the quote unquote movable middle. People who are not anti-vaccine, but they feel like they need more time. They're waiting and seeing until they feel comfortable. It's really important not to conflate this group with those who are strongly opposed to ever getting vaccinated ever, which is the darker green portion at the end of the graph. And I included a quote here that I found helpful from the Rockefeller Foundation Vaccine Confidence Message Brief from a few months ago. They noted there's an important difference between resisting the vaccine and waiting to be convinced. Next slide, please. Okay, here are a few quotes from our work on the COVID vax study. So these are from interviews done with healthcare providers at federally qualified health centers. The first one I'll read through talks about healthcare workers being from the community. We hire from the community. That's a really important part of our community connection. So I included this quote for this presentation because when we interviewed providers, when they talked about hesitancy, they really talked about hiring from the community and the hesitancy among their staff mirroring that of the hesitancy of the communities they were serving. And I think there's sometimes a feeling that somehow healthcare workers are different or special from, and they are special in the work that they do, but they are also just regular people like the rest of us and have the same concerns. And so I wanted to emphasize that by including that quote. The second quote is from a healthcare worker, a nurse in Tennessee, who says, "I was on the fence. It's always scary when something new comes out. And I was worried about side effects, and I had already had COVID. So I thought I don't really need it." And this was an interview that I did. And this was definitely a person who was not anti-vax. She vaccinated her children, but her feeling reflects a few common concerns and thoughts of, these are new. I was worried about side effects, and I'd already had COVID. I didn't think I needed it. She did eventually choose to get vaccinated, but she took some time to make that decision. The third quote is from someone in New York talking about a fellow coworker saying, "One of our coworkers was a little scared. She actually does have a pacemaker. She's African American. So she was really scared because of the statistics. And then she's got chronic medical conditions and things like that. And I chose to share this quote because I think it reflects that some individuals may feel that the vaccines are generally safe or safe for some people, but they're not sure that the vaccine is safe for them specifically. And this may be especially true for people from hard-hit demographic groups or those who have underlying medical conditions. And then the last quote says, in the staff, we see a lot of not yet, not really no. We employ a lot of young women, and there are a lot of questions about the impact on fertility, on pregnancy. And this quote, I feel like, reflects concerns that we're seeing more among younger people now and younger healthcare workers regarding safety during pregnancy, and some of this, reflecting that the vaccine trials maybe didn't include pregnant women, and I think also what gets mixed in there is some common misinformation about an impact on fertility, which is not the case, but it kind of gets in the mix there. Next slide, please. Okay, and then this last quote, I'll just read. It's a lengthy one, but it's an important one. This is from a Black healthcare worker in Tennessee, and she said, I don't know if it's necessarily that people are hesitant. They're rightfully fearful. Particularly Black and brown people, anything involving a needle can't be trusted. Like Depo-Provera was tested on Latina women, right? Mississippi appendectomies, injecting titanium into people. Like, we don't do needles. That's not hesitancy, that's protective. And nationally, the narrative is they're hesitant. No, they have data to support them protecting themselves. And I've been impressed by the number of Black and brown people who, despite that history, have said, you know what, I'm getting this because I've seen what it's done to our people. And for me, I wish we could delete the word hesitancy, like it's literally protective. So I think of this person every time I use the word hesitancy because I really, I think she makes a great point, and we need to think about what that word does and doesn't do for us. Next slide, please. Okay. Before I wrap up, I just want to talk a little bit about special considerations for healthcare workers and COVID vaccination. So there are a few things that I think healthcare workers face in particular. So healthcare workers face a burden of social expectation that they will vaccinate and that they will vaccinate first. This is a kind of a double pressure, right? The pressure that you will vaccinate because the nature of your work in a healthcare setting, and that's much more pressure than probably almost any other profession gets, except for maybe teachers. And then this expectation that you will vaccinate first. And for some, being first in line was a validation of their higher risk and exposure to risk and the important role that they play in fighting the pandemic. But I think we also need to remember that for others, it may have felt like being asked to be a guinea pig. And so it's important to remember that not all healthcare workers experience prioritization as a positive or an affirming thing. Secondly, for healthcare workers, vaccination hesitancy or hesitating to get vaccinated, it's kind of a shame game, right? There's an implication that waiting to vaccinate is shameful. And this is implicit in messages that refer to vaccination as heroic. And I didn't mean to single out MSK by choosing this image, that we could have found that heroism language really anywhere. But I think and I know it's well-intentioned, but I think it raises the question, are you no longer a healthcare hero if you wait to vaccinate or if you choose not to? And this comes in the context of larger cultural narratives suggesting that healthy people who don't vaccinate are quote unquote selfish or quote unquote free riders. This is the kind of language that we've seen in some opinion pieces and op-eds and things like that. And then lastly, because this is a New York State group, I want to acknowledge, and maybe some of the downstate folks can speak to this probably more eloquently or firsthand than I can, but to the trauma of the spring of 2020, in which healthcare workers in New York City worked under conditions of tremendous risk and distress. The lack of knowledge about the virus and how exactly it spread, the shortages of PPE were just really, really traumatic. And they experienced an incredible amount of risk. And they may feel, for those who are now deciding to not get vaccinated immediately, they may feel like their employers and potentially colleagues are dismissing their concerns about safety after they really were down in the trenches. Okay, next slide, please. So a few ideas, I'll just wrap up with a few ideas about how we might respond respectfully. So I would first emphasize having a dialogue, not didactics. So listen to people's concerns, have a conversation, respect their beliefs and feelings, even if you disagree with them. Don't employ a top-down approach of quote unquote correcting them. Secondly, encouraging conversations with trusted healthcare providers. This can help people get an answer to the question of, is this vaccine safe for me? And I think Kara Simpson is going to speak very eloquently to that in just a few minutes, so I'll leave that for her. But I think that's a helpful thing for some people. And then lastly, I just want to say to remember that the onus of trust should be on healthcare institutions, and which in this case we're talking about also as employing institutions, not individuals, not employees, right? And what I'm trying to get at here is that there's a lot of talk about how to get communities of color and Black people in particular to quote unquote trust healthcare institutions. And this really racializes trust. And I should say I'm borrowing work from Ruha Benjamin here again. This racializes trust in that it puts the burden on people to trust rather than on institutions to act in trustworthy ways. And so I shared this last quote from the Vax interviews because I thought that it really spoke to that. This is, again, a provider at an FQHC saying, it really takes some time to demonstrate that, in fact, one respects and one is respected. And once you do that, then there begins to be a foundation of trust, but that it takes time. Next slide, please. So a final thought along that note is from Heidi Larson, who I mentioned earlier. She is the founder of the Vaccine Confidence Project and an anthropologist. And she said recently in a New Yorker profile, we should not forget that we are making people's future history now. Are people going to remember that they were treated respectfully and engaged? So if you could just go to the last slide, I'll just say my thank yous. Last slide, next slide, please. There we go. Thank you to my COVID Vax co-investigators and our FQHC partners. So co-investigators Nancy Berlinger, Carolyn Newhouse, and Danielle Pasha at the Hastings Center, Rachel Faby at SUNY Upstate. Thanks to Empire State Bioethics Consortium and also to Alden March Bioethics Institute. And I'll turn it over to the next speaker. Thanks everyone for listening.
Thanks, Johanna. So our next panelist is Kara Simpson, who's going to present her perspective as a social worker, psychotherapist, and bioethicist. And before she gets started, I just want to remind people to offer questions in the chat on the right side of the screen so that we can make this an interactive session throughout. You can enter questions. Thanks very much. Thanks, Kara.
Thank you, Jenny, and thank you, Johanna, for that wonderful presentation. I come to you all, as Jenny said, I am a social worker, director of social work here at Jacobi for behavioral health, bioethicist, and someone who is formally vaccine hesitant. And I thought it was, really fitting to, just discuss it from a multi-layered perspective, my personal professional experience with this issue. And so it's multi-layered, and I just hope you all really take away something from it. So first, I want to start off by, one, acknowledging that it's just going to be me talking to you as opposed to slides. I do love PowerPoints, but I do feel like this is more just me speaking to the audience about experience, both personally and professionally. The bigger question that came up when I'm talking to my colleagues in the consortium is, why are people hesitant, and the origins and foundations of the hesitancy. And I actually did reveal that I was very much hesitant to accept this medication that just came out on the market and was highly politicized, and I was definitely fearful and distrusting. The foundations of my distrust are very deep, more personal than anything. I am a Black woman, born and raised in the United States, and we all are, if not, you don't know now, you will definitely know the history of our of the atrocities that have been done to Black and brown people by the medical community. We have always, we've had to endure experimentations, just needless, how I don't want to call it. I said experimentations, but more just abuse, just total abuse to our bodies. And that's not unfortunately, that's been an experience that's been reoccurring in this country. And so when seeking medical care or having any medical concerns, though it may not have happened to me individually, it's definitely happened to family members, and it's happened to my generations and generations and generations beforehand. And we all know that trauma is generational. It can be passed down to generations. So when you're distrustful, it does actually come through the family lines and the communication and just how we approach certain things. So despite my healthcare background and my other family members having healthcare backgrounds, there is the general distrust towards the institutions because of what we have as Black and brown people have experienced. Now, besides that, there were other reasons why I was hesitant. I can imagine, or I'm sure everyone can imagine, when the vaccines were created, it was obviously very, very fast. We were still in the height of really trying to get through taking care of patients, taking care of our institutions. Burnout was at an all-time high. So we were hearing of this vaccine coming, and then it was finally here. I think it was just so fast that a medication was out on the market. Well, not on the market. It was ready to be introduced to front lines. I know I didn't get a chance to really wrap my head around all that's happened. So when you're in a medical field or have some type of medical training, we usually tell folks not to take the first medication, make sure it's on the market so we'll know it's safe. And you give it a few years for testing and trials and seeing what happens, side effects and outcomes. And it didn't feel like this happened, or it didn't feel like it happened. Let's say it didn't happen. It was just, again, rapid, or what was called warp speed. It was produced and the expectation was, hey, it's here, you take it. And what I found a little troubling was that as a clinician, a social worker, when trying to do education, my own education, a lot of the information that was out there was really based in data and statistics and information that was really, a lot of times, really indecipherable. I'm not a mathematician, I'm not a statistician. I just really wanted to understand how would it affect me immediately and long term. So since I wasn't able to really receive that information, I was obviously very, very skeptical. I like to call it a healthy skepticism, but it has protected me. And I thank Johanna for mentioning the protective factors. This was my way of trying to protect myself around not having any adverse effects. Also, I am a healthcare worker. I am a Black woman. Those two are not, separate and aside from one another. I have been in healthcare for about 17 years. And my concerns is that as healthcare workers of color, we're not often talking about how not only we are members of the same community, that we're treating patients that are coming into our hospitals, but we have also not only experienced healthcare issues receiving healthcare or having healthcare traumas, but we've also most likely have witnessed it, as in what happened with COVID-19. So with seeing and experiencing and being what I would call re-traumatized over and over again, it will heighten your hesitancy. And so that was something that really, to me, settled into me and again made me hesitant to say, well, I'm going to roll up my sleeve and take a medication that really hasn't been here for a while. And finally, I think what really totally heightened my hesitancy was the pressures from my institution, my employer, the news stating that the Department of Health was going to really hold my employers accountable for raising these vaccine numbers. When you have such pressures and it's tied to your employment, especially when it's a very political issue, the response will usually be backlash. I'm not going to do this because of making numbers happen or increasing someone's productivity or compliance numbers to meet very superficial mandates. It felt like I wasn't being taken into consideration. My family wasn't being taken into consideration. It was about someone else's gain. And that will never really sit well with me or at most other individuals where they feel like they're being used, especially with the history of distrust of a medical institution. So what changed my mind? What's interesting is I thought a lot about this, and full disclosure that I have asthma, and I know asthma gives me a higher criteria or a risk for extracting COVID and not really having a good outcome. I'm a mental health care worker, Black woman in an urban area with asthma. That's really higher risk for contracting COVID and not having a successful outcome. So I actually went to my pulmonologist just to have a regular follow-up. And it was my pulmonologist that actually talked me into taking the vaccine. And what was very interesting is what he did for me was he actually told me the risks of the risks and the benefits. He told me about the risks and benefits that actually related to my sense of well-being. This was the first time that it actually came up that was related to me, not my institution, not my community, not how it would be benefiting the larger community. It was more, what's this going to do for Cara? And what would happen to Cara if she didn't take the vaccine? Or what would happen if she did take the vaccine? And that really, really changed my mind completely, because my doctor, I have a very good relationship with him. And that just brought up a whole nother level of, well, what if I'm another healthcare worker who does not, or even not even a healthcare worker, just a member of the community who does not have a trusting relationship with their providers? I just happen to have that. And again, as being someone whose people have a history of distrust to the medical institution, it is not uncommon for not only other healthcare workers of color, but just people of color in general to not have trusting relationships with their providers. So I was very fortunate to have a doctor that cared enough to really explain it to me for me, that I can understand and know that I trusted him. It wasn't a politicized statement. It was one out of genuine care, and it was very professionally delivered, so I could receive it. Despite my general distrust of the system, I trusted him. And that made all the difference in when we were talking about institutions and how institutions deliver the message. Like Johanna referenced earlier, trust is a key factor, and it often is the onus, the responsibility is put on the patient, in my case, or the employees, instead of really trying to cultivate a relationship of trust and acknowledging why they are distrustful. And if you notice, I keep saying distrust instead of mistrust because I firmly believe that mistrust is it connotes that there is a relationship or a trust breakdown between two individuals, whereas distrust is a larger context. Distrust is in a larger context with evidence to back it up. A lot of Black and Brown people and Asian community, Native American community distrust the larger medical institutions because of the factual evidential things that has happened. Catastrophic circumstances have happened. So I use distrust to really bring home that this is a larger issue. Now, it could be countered or counteracted, I should say, by building more trusting relationships over time where institutions are invested in helping the communities more transparently without any show of gain for the institution. It would really need to just be very pure and genuine, and we can eventually over time build trusts. And so I just wanted to really impart that the the takeaways that I took away from it were that how important the clinical relationship is and how we as healthcare professionals really need to do a better job at establishing those relationships because it does make change. And there's a larger community that really will have a standing distrust to the institution because of history and because of poor current relationships that can really contribute to further deteriorating outcomes. So as far as ethics is concerned, I really want us to concentrate on reestablishing the importance of the clinical relationship, especially when it comes to marginalized communities, because those are the things that really are going to move the needle when it comes to vaccine hesitancy, and dare I say, maybe even anti-vaxxers who do not have information, or it's really not connected to how they may be impacted or have been impacted by the medical institutions. So I also want to just close off by talking a little bit more about the shame piece. Johanna again mentioned shame and how at one point there was a period where in the hospital institutions, the culture is to talk about it. Like, well, are you going to get it? Are you going to get it? And if you didn't have it, not only interpersonally, you felt a little shamed by those who received it, but institutionally there was a pressure, and if you didn't, you weren't that stand-up employee. I totally experienced that even in my position of being a leader here. And I think we really need to reconsider how we take care of our workforce, emotionally, psychologically, and as a whole, because shaming is only going to add to the distrust of the institution. So that's pretty much what I wanted to contribute. But I thank you all for having me and listening to my story. I will be here for questions, and I want to hand it back off to Jenny.
Appreciate your thoughts. So our next panelist is Ashley Stewart, who is the vaccine, the vaccine rollout czar, the nurse who managed the COVID vaccine rollout at Carthage Area Hospital, and she's going to talk to us about the institutional approach and her experience over the last 6 months upstate. Thanks.
Thank you so much for that. My name is Ashley. I am the infection prevention coordinator for Carthage Hospital, and I was in charge of the vaccine rollout. I'll start briefly just by saying hi, and it's an honor to speak here for all of you, especially about a topic that I am very passionate about. I do have some slides that I will put up just shortly. And just because there's some things that I want to put in here that really echo a lot of what the speakers before me have said that I discovered doing vaccines in our area. if we could go to the next slide, please. So Carthage Hospital, we're a critical access hospital, which, if you look at this map, so we're kind of in this little blue area. If you look just above that blue area, that is Canada. We are a very sparsely populated area in Jefferson County. We do not have a high minority representation in our area. We also have a poverty rate roughly 2 times the national average. We also have a large section of our population that's greater than 60 years of age and therefore very high risk. We are a 21-bed critical access hospital, and critical access as a designation is something that's done for rural healthcare centers that have special needs or special distinctions that allow us to kind of work within the framework in different ways. To be a critical access, you have to have 25 or fewer inpatient beds. Those beds can be flexed to do long-term acute care, patients who need inpatient antibiotics, things like that. You must be located 35 miles or more from any other medical institution, which there are some exceptions there. And you have certain requirements as far as providing 24-hour emergency care and other things. Basically, what this means is that we're a very small institution in a very small area. And because of that, our institution, we directly employ 500 people or less. I think 500 is close to the maximum number of people that we've employed at any one time. And in our area, and I'll echo this from the speakers before, we really do employ people from our community. A lot of our providers are contract, but most of our nurses, most of our full-time staff are from the area surrounding us, and therefore echo a lot of those concerns. As far as our vaccination data, we had a very slow start. So in the beginning, we only had, after about 90 days, so we started vaccinating in December of 2020. By February 2020 or mid-March, 53% of those applicable were vaccinated. And so we realized we had a little bit of a problem. And when I say a problem, I mean we were getting a lot of criticism from entities outside of our hospital, the state and other institutions in some circumstances, where they were concerned that our vaccination rates were quite low. Currently, we're at 77%, and I'm here to kind of explain or go through what we've done to impact this, because it was very important to me and also the administration at Carthage to ensure that we increased our vaccination rates, but in an ethical way, because that's something that was very concerning to all of us. Next slide, please. So during the time that we did vaccines, there were a lot of things that I observed. Some of these things I'm sure you've seen. The first one is a lot of telling people get vaccinated, which in my opinion doesn't work. I feel like by the time vaccines came out, COVID-19 had been around for so long that people were getting incredibly tired of being told what to do. A lot of our staff, though we do not have a high minority representation, even within our community, which is predominantly rural, predominantly white, non-Hispanic, non-Latino, and I would say also in the majority, heterosexual or heteronormative people, the mistrust was there from really the starting point, because after being told every single day what to do, how to do it, they were very exhausted with it. And so that was something we did have to work past. The next thing that I saw a lot of in a lot of hospitals in our area said, make people go to a town hall. If they aren't already vaccinated, make them go to this event so you can explain to them all of the things they need to know about getting vaccinated. In my opinion, this also did not work in our area. So we started vaccinating in the middle of COVID wave 2, which did hit our area not as hard as New York City got hit, but in our area, much harder than we had been hit previously. And basically all of our staff was working overtime. We had flexed people from different departments to work inpatient to take care of COVID patients, things like that. And so telling them that because you didn't get vaccinated, you're now required to go to this next event, was not taken very well. And I can't imagine why. People really wanted their time to be respected, and they were already giving so much time to the institution and so much time to caring for patients. They were truthfully exhausted of things like that. The other thing that I saw a lot of, which follows with the speakers before me, is a lack of information. A lot of my staff were not against vaccination, but said that the information that they needed, they just didn't have. And finding information that was not politically biased or pulling from one side or the other was very difficult for them, and that bothered them. A lot of them voiced to me that their concern with this was that they wanted the information and to make a decision for themselves, but making that decision was being taken away from them by being told they had to get vaccinated or should get vaccinated, or feeling like they were being told that this was a decision that had to be made, even though the information that they wanted or acquired wasn't there at the time. The other thing I saw quite a bit of was politics and identity. And in the area where we are, I found this unusual because we are predominantly white, predominantly Hispanic, predominantly heteronormative. I didn't expect this to be such a big issue. Now, to be clear, I never had anyone say, I'm against this vaccine because my political party isn't interested in it. What I had a lot of people say to me, though, was, I'm afraid of what people will think if I ask these questions. The last bullet point is no one wants to raise their hand in a crowded room. And the reason I put that in there is because a large group of people that I spoke to after the fact, after we started the rollout, and then when we started making the changes, was that they were concerned of how they would be interpreted or what it would mean if they were a white person who did or did not get vaccinated. If you're the only person of color, the only queer person, or the only male that's working on your floor, if you do or don't get vaccinated, what does that mean politically, or what does that mean for your identity? And I had a lot of people who were very concerned about that, but they didn't want to voice those concerns in public in a town hall. No one wants to raise their hand with 50 of their coworkers around and say, I'm concerned about my fertility or things like that, because that can mean very different things to different groups of people. And there was a lot of concern about that. And so this is kind of a summation of my observations. Next slide, please. And so we took a little bit of a different approach to how we did this, because telling people to get vaccinated wasn't working. And I realized after a few months talking to people that there was going to be difficulty getting the information to people that they needed and having the conversations. So the first thing I started was a weekly newsletter. I called it the COVID mail. We sent it out every single week from infection prevention, and it gave a lot of information that was very practical that people also felt like they were missing. I think that may have contributed to distrust, but it gave information about PPE changes, travel changes, and then also allowed for an anonymous question and answer session where if someone submitted a question to me, and there's another check just below this or just next to it, where I was accessible to people by phone or email. They were allowed to remain anonymous by phone if they wished, or they could write a question on a piece of paper, and I would answer those questions submitted anonymously in this weekly email. So if you submitted a question to me about fertility or about other concerns that were voiced, such as there were a lot of rumors that went around about what would happen if you did not get vaccinated. Would your institution get punished? Would you not be allowed to eat in the cafeteria? Would you lose your job? And things like that. And they could submit those questions, and I would answer them publicly in this email that everyone got. Also, I made myself available 24/7 by phone, and then also by email for questions, because I'm not a provider, I'm not a physician. For questions that I was not able to answer, I did have a physician at my institution that was helping me with this. They're a wonderful person, and also was available to me 24/7. which allowed me to get information or answers to questions that I needed for the people, because I found a lot of times people would not think about this during regular daytime hours. They would get home, they would eat dinner, and then at 8 o'clock at night, they would think, should I get vaccinated? And then they would contact me and have questions for me. And so I made sure to be available for that. A lot of what we did was just listen, because as it was stated before, a lot of the people who are hesitant or not sure about vaccination are not anti-vaccination. They just wanted to know if vaccination was a good fit for them. There were concerns that went around about, would this vaccine cause infertility? Would this vaccine cause issues with long-term chronic health conditions? I had several people who spoke to me who said, will I get punished if I don't get vaccinated? I have one employee who shall remain nameless, who is currently undergoing treatment for cancer, and their oncology team told them, because they're currently doing chemotherapy, that getting the vaccine is not a good fit. And their question was, will something bad happen to me if I don't get this? Do I have to explain why I didn't get it? Because they were not ready and are not ready at this time to tell their coworkers that they are going through treatment for cancer. I had a few employees that said, I don't want to get it yet. I'm pregnant. My boss doesn't know yet. And so a lot of conversations needed to be had, and a lot of talking to individuals, learning their concerns, and then helping them get the information that they needed versus helping them get vaccinated. The push at the time was get people vaccinated. And for us, we changed our mentality in a way to get people the information so they can decide to get vaccinated or not. The next thing we did was quite a bit easier, which was facilitation of access to vaccination. So if a person said, you know what, I made the decision, it's my decision, I do want to get vaccinated, then we went into kind of high-speed mode. So if you want to get vaccinated, I would ask each employee that made that decision, what vaccine do you want? Do you want Johnson & Johnson? Do you want Pfizer? Do you have a preference? And then I would do everything I could to get them that vaccine. My goal was always within 7 days. In practice, it worked roughly in about 4 days, that any person who decided to get vaccinated had access to the vaccine of their preference as quickly as possible. And the last thing that we did was we made a policy of no shaming, no threats, and no special treatment, which to us means we were not in the business of telling people that they should or should not get vaccinated. We did not make special things for people who did or did not get vaccinated. There was no, if you get vaccinated, you get a day off. There was no, if you don't get vaccinated, you have to attend a weekly event telling you about vaccination, because to us, until this is not as new and until people are comfortable, myself, and fortunately with the support of my institution, who have been wonderful and have supported this and taken a little bit of grief from a lot of entities outside of our facility, we really set down to approach this as a way of saying everyone gets treated equally. We will not force anyone to intentionally or unintentionally disclose their vaccination status, which meant a lot of not allowing policies that require people to disclose their vaccination status against their will. And obviously with new guidelines that come out every day and things change, we don't have as much of an option there sometimes, but we're still dedicated to this and dedicated to saying we're working to maintain the dignity and the autonomy of our people, to respect their intelligence, to allow them to make their own decision, and to do whatever we can to maintain equity with everyone, regardless of their decision. And that's really been something that's worked very well for us incidentally, and also hopefully for the people who work for us. I'm glad that the 24% of our staff that got vaccinated after the initial push all did so without the use of coercion, and that they all made that decision comfortably, and hopefully none of them felt pressured to do so. And other than that, that's all I wanted to say. And I will turn it back over to Miss Jennifer.
Hi. Thanks, Ashley. So our next panelist is David Hoffman. He's an attorney who actually brought us to Ashley. He works with several healthcare systems upstate and is a bioethicist and lecturer at Columbia. Thanks, David.
Oops. Thank you, Jenny, and good evening, everyone, and thank you, Ashley. Let me say, Ashley and I have worked together at Carthage Area Hospital for years, and we have really drawn on that working relationship in a huge way to work through all of these questions, many of which we're still working on, and in fact, we're working on as late as this afternoon, because we're dealing with what to do with the new OSHA regulations that we won't get into, but that are going to have a profound impact on the workplace that is a hospital. So Jenny asked me to wrap up by addressing the elephant in the room, right? Vaccine mandates. In fact, interestingly, one of the participants asked the question just a couple of minutes ago, do doctors that refuse to get vaccinated get fired? And so let me answer that question. Yeah, maybe. And when we talk about vaccine mandates, let's be very clear that we're talking about mandates in the employment context for private employers. Government has not yet gone to the notion of a legal enforced governmental mandate, such as the mandate to pay taxes, because of a variety of complicated legal reasons. But in the private sector, the reality is that employers can require their employees to do a great many things, and one of them is to get vaccinated. And that gave rise to the lawsuit that occurred down in Texas involving Houston Methodist Hospital. And in that case, the employees, 177 of them, went to court and said, Judge, my employer should not be allowed to force me to get vaccinated. That there should not be an obligation that I have to get vaccinated. And what the judge said, and really what we all need to recognize, is that no employer can force an employee to get vaccinated, but no employer has to continue the employment of any employee who declines to follow the rules established by that employer, including the obligation to get vaccinated. And so what happened in Texas is the judge said, you are not being forced to get vaccinated, but your employer is allowed to set limits and conditions on employment, including vaccination. And so the answer to the short question is, you don't have an obligation to get vaccinated, but you also don't have a right to your job, right? And that's because of two related legal concepts. One is the notion of a right to work, which is a misnomer. And the other is the notion of employment at will, which is also a misnomer. So the right to work is a phrase often tossed around, but it really doesn't impart a legal right to your job. It is in fact a euphemism for the right to work without being compelled to join a labor union. And there are right to work laws in many states. Likewise, employment at will sounds like, you can do what you want. But in fact, employment at will is the unremarkable notion that you can quit your job whenever you want. We don't have indentured servitude in this country. And at the same time, your employer can separate you from your employment at any time for any reason, or no reason, except if the reason or the pretext is one of the protected statuses: race, creed, color, gender orientation, gender identity. Other than those criteria, any employer, including any hospital, and including obviously in Texas, Methodist Hospital, Houston Methodist, can decide if you're not willing to get a vaccination, or if you're not willing to do sexual harassment training, or if you're not willing to do the infection control course, fine, that's your right, but we're not willing to have you working here anymore. Which leads us to really the final point, which is that, yes, private employers, including hospitals, can deprive an individual of their employment if that individual refuses to get vaccinated. That's the legal point. The ethical point is, just because we can do that doesn't mean we should do that. And in fact, the vast majority of hospitals have elected not to require their employees to get vaccinated, but have in fact adopted the approach that Ashley really quite beautifully described, one of support, respect, and gentle ethical persuasion. I should note, though, late breaking news, the state of Connecticut and the state of Massachusetts hospital associations have just in the last few days adopted positions that hospitals ought to mandate vaccination for COVID as a condition of employment. So I'll stop there and hope that there will be a vigorous discussion of all of these questions. Thank you, Jim.
Great. Thanks, David. So I'm actually going to speak for just about 5 minutes about my own experience here at Maimonides briefly, and touch on some areas that weren't touched on yet. So I have two different stories to tell. So one is as the co-chair of the Bioethics Committee at Maimonides. So we have a community hospital, very large teaching hospital, and we were very hard hit by COVID last March. After 9 months of work on inpatient medical units with a lot of suffering colleagues affected by the illness, our chair of medicine actually passed away with COVID. So the institution was really hard hit. I felt tremendous frustration back in December with the idea that the vaccine would be rejected by the healthcare workers and the employees here at Maimonides. And as the co-chair back in December of 2020, and a number of our other members of the committee, I drafted a statement from the Bioethics Committee recommending vaccination for all employees. And it was a little more nuanced than that. It described the fact that we had all been through a tremendous trauma as a community, and we had pulled through, and this is an opportunity to protect ourselves. But ultimately, the wording was very clear about recommendation coming from the Bioethics Committee. And then I started to discuss this draft with a number of different people, including people from the Empire State Bioethics Consortium, many of my colleagues here, nurses, administrators, other physicians. And in the end, we didn't release the statement. And I would say, fast forward, I'm pleased that we never released the statement. We directed our efforts to creating a dialogue, or trying to create more dialogue. And that process of thinking about recommendation is one that I'll come back to in a few minutes when I tell you the second story. So the second story isn't about healthcare workers, actually, but about another priority group that I was involved with. So I have a relationship with a not-for-profit organization in Brooklyn, which operates 7 Head Start early childhood education centers in northern Brooklyn. And the executive director asked me in February, because of my experience as a physician and my interest in vaccine rollout, to think about how to message the COVID vaccine to her staff, which is exclusively people of color. So there are 110 staff involved in this organization, and they were exclusively, almost exclusively, American-born people of color, or people of color from the Caribbean islands. Almost entirely women. So talked with her briefly, actually talked with her at length about how to go about messaging. And this was sort of going on in tandem with this conversation around the Bioethics Committee and the rollout here at Maimonides. So to reference something that Ashley said, we did actually have a town hall on Zoom with 20 of the staff who pre-selected themselves, said they were interested, but concerned about having conversations. And we solicited questions ahead of time that I had a chance to think about. Some of them were much the same questions, actually, that Ashley mentioned around fertility, around cancer creating vaccine, the vaccine creating cancer. Very few actually around acute side effects, but long-term chronic conditions were brought up a lot. And I spent half the time on the Zoom call answering these questions about the side effects that they had given me kind of pre-selected. And then half the time was spent on kind of ad hoc questions. So I was available, on the screen answering questions as they would come up once the group was warmed up. And I'll tell you that I was extremely nervous about how the audience would perceive me. I was a white doctor who they didn't know, and especially given the concerns about ethical abuses of people of color in the past by the medical system. I felt awkward about coming to them. And there was a lot of conversation in the press and also in our, at Maimonides about, the messaging happening through other providers of color, that might be the best way to message because there would be more trust. But I also kind of felt like I shouldn't back away from this opportunity if I was respectful. So I chose to simply name my discomfort at the very beginning of the conversation. And I said something like, thanks for having me. As a white physician, I understand you might have concerns about trusting what I say. 400 years of inequity and abuse by the healthcare system can create a lot of mistrust. But I'm here to try and answer your questions. And ultimately, the executive director reported that there was a successful rate of vaccine, and it's almost equivalent actually to our rate here at Maimonides at this point. There may be even more now. So she at least considered it a useful interaction. So anyway, to circle back, I think the critical piece is the intimate, open conversation where you can elicit values and it's not a didactic experience. I really don't believe that any recommendation from the Bioethics Committee would have resulted in more vaccination. And I think it would have created a tremendous amount of friction with other individuals, would have forced more problems in the future. Ultimately, I really do think that the ethical issues that recommendation brings up have to do with organizational ethics. So we're used to the idea in ethics at the clinical case and focused on the individual. And I think one of the things that the COVID vaccine rollout has brought up is that many of the distributive justice questions that we're concerned about are really related to organizational ethics. And they're contexts that we haven't had as much conversation and comfort with as bioethics committees. And we need to maybe grow that muscle a bit and have more conversations. And I wonder what others think about this on the panel. I also think that developing relationships with the C-suite and the comfort that the executive in the hospitals have with our support and our thoughts about what is ethical as the bioethics committee may actually improve the ability to make recommendations in the future that make more ethical decisions. So I want to open it now to questions. And I actually first want to ask Tara a question that was asked. And now I have to find it. There it is. So Kara, what about this question comes from the chat. What about your family members? How did they feel about your decision-making process, and were they influenced by your decision to take the vaccine or your initial deliberation around it?
Well, thank you, whomever answered the question. I think it's an interesting question because, again, my family is the community, and we're health. Some of us are healthcare. Most of us are healthcare workers as well, and there was still hesitancy. And so, me explaining my position and hearing their position, and really just having an open dialogue about it. Some remained hesitant, some did not, and I think the important piece of having the conversation is not to change anybody. It's not to necessarily try to flip, from hesitancy to vaccinated. That's not the goal. It can't be the goal. I think the goal is really to hear people out, validate concerns, talk to them about the benefits to them and to us as a community, a family, a collective, and really have some understanding and respect around decision making. And so we will continue to be some folks who didn't want to take it. Well, we practiced, social distancing, masks, and all those things. But again, I don't think the approach was to flip anyone. That's not it, because that's another pressure and a shaming factor that I don't subscribe to. But I also want to add, this conversation did come up in my private practice a lot. I see mostly people of color in the therapeutic relationship, and again, lots of hesitancy. And, it was very interesting to hear the same thing kind of over and over again. So what I did position was, well, how do you talk to your doctor about it? Do you speak to your doctor about it, or is it just you making this decision in your living room on the internet? Do you speak to a medical professional besides myself about this, and what would it mean for you? And most of them said no. And so, not only did I encourage them to find a doctor, a PCP or primary care or whatever kind of doctor that they can trust and really feel connected to, that should be another step for them to explore the situation further so they can have a true assessment of the benefits for them. And I know it worked for me, and I hope it worked for them too.
Thanks, Cara. I have a question for Ashley. So you described a similar situation around shame that was operating with the healthcare workers, and the concern that some people voiced they were hesitant because they were Republican and didn't want to express their concerns. Did you have a sense that it was because they were afraid of being seen as hesitant, or because they were afraid of being seen as Republican?
So for my experiences specifically, it wasn't just Republicans. I also had Democrats, I had independents. The concern wasn't what would they think about me as a Republican. It was my friends do or don't share my political views. What will they think if I ask this question? If I raise my hand in a room of my peers and say, is this vaccine safe? Will they think it's because I'm concerned that the vaccine is safe? Or will they think it's because of my political views? Will they agree or disagree? Will they respect me more or less? And it really wasn't a question of specific political views as much as it was the concern. In our area, it's a very small area. A lot of the people who work for us have worked for us for a very long time. And their concern is more so, this is a community, and losing the respect and the faith of your community is hard to put together, especially when you're talking about losing or maintaining your health or the health of your patients. There was never a question that they wanted to do the best for themselves or their patients, regardless of political views. It was more so how it would impact them outside of that and what that would do to the relationships that our institution and our community is built on.
Great. Thanks, Ashley. Does anybody else in the panel want to respond to that? I have another question I can ask.
Well, I just wanted to add to what Ashley was saying. What we have seen up in the North Country, that area north of the New York State Thruway, is the same political situation we see across the country and across the political spectrum, which is that we all live in our own little news bubbles. And so there is an enormous amount of misinformation on the left and on the right about the positions about vaccination and COVID in general and testing and wearing masks that we need to gently and respectfully disabuse in order to get everyone to share a single set of facts, right? Daniel Patrick Moynihan said, everyone is entitled, excuse me, to their own opinion. Everyone is not entitled to their own facts. So that's the challenge.
So I've got a question that anybody could respond to, but I think it has to do with messaging. So it might be more appropriate for people that are actually messaging to people in written form. But so the question is, how do you decide how to word your messages?
I personally dealt with this a lot. For the most part, it was a matter of asking myself roughly 3 questions. The first question I asked was, would I be answering the question this way if this patient was already vaccinated? So I made it kind of a point of pride that I was an area that I could, essentially my job was to provide information, not to get vaccination. So would I give this same information to a vaccinated person in the same way? Because if I wouldn't, then it is biased. And to change the messaging for those who are not vaccinated or those who are was something I tried very hard not to do. The next thing I did was look at it and say, is there a way that I could phrase this that sounds less like I have a bias? I'm personally very pro-vaccination. I think that it has helped much more than it's hurt, though I can't say that it has never hurt. But I would look at it and say, is this a message that I would agree with if I didn't have an opinion? And then the last thing that I asked myself, which is inherently problematic, and I apologize, is in a year, if we found out there was something that went wrong, would I feel responsible for these decisions based on the information that I gave out? Giving information that's available at the time is one thing. Giving information to purposely skew someone's judgment is another. And one of the largest questions I asked myself very frequently was if I would feel comfortable with the statements that I made and the information that I gave if it turned out that I was wrong. And that's the 3 basic criteria that I used before I answered any questions or gave any information, and hopefully it worked. You'd have to probably ask my coworkers.
Anybody else? I have one thought. So something that Johanna said at the very beginning about hesitancy, that she wished that we could reconsider that word. So I've thought a lot about the power of a word like deliberation, or you could say low confidence. How to message differently, I think from the beginning might have been very useful. So we try to use the words, patient has not chosen the medical plan that the physician outlined, as opposed to non-compliant. I do think those words have an impact ultimately on the likelihood that somebody will see you as a partner. So we've got some big sort of civics questions in the chat, and I'm trying to, I'm going to read one. So because the US is a country that is all about individual choice, freedom of choice, does more choice lead to feelings of more vaccine hesitancy than how people feel in other countries? Do we think that more choice leads to more hesitancy?
I can say something about that. I don't have a data-driven answer for that question. I can say that I think generally speaking, we know that even in the U.S. that even within the U.S. that ultimately, like the greater amount of flexibility you have around vaccination, that you will have more people opt out, right? So when states, for example, take out their personal belief exemption and say the only reason you can opt out of this is, and I'm talking now about like childhood vaccinations for school, you know, the reasons you can opt out now are only medical or religious, or in some cases only medical, right? This is a state by state thing. So when states change that and they take out the personal belief exemption, the vaccination rates do go up. So in that sense, I think that's not a country by country answer, but there is evidence that, you know, less choice does lead to higher vaccination. There's also a lot of historical evidence that mandating vaccines creates backlash and fosters further mistrust. So I think we have to take those two things together. And, you know, I think an important thing to say here is, you know, as someone who's, you know, historically worked in global health, that the US is in a tremendously privileged position right now because of our access to vaccine, and that most countries don't have the privilege of mandating vaccine because they don't have access to it. So that's a whole additional conversation, but just to remember that we're in a really privileged position to even consider a mandate at this point. And I'm not saying that's the way we should go, but just to keep the global picture in context.
Mm-hmm. Mm-hmm.
And I would add to that, Jenny, if I may, I would add that it's important while we are discussing vaccine and all these other words that we are using to characterize people who have not yet vaccinated, we need to be careful into looking at it not as a static position, but more as an evolving position, which offers opportunity to continue those conversations. Because in reality, if you look back to January and February, the UK was in an ideal position. There were also decisions made by NHS to give one dose rather than two doses. And now they're dealing with the Delta variant. But the United States, as of yesterday, even surpassed New Zealand as the country with the highest rate of vaccination. So we need to also take some solace in the fact that the vaccination campaign in the United States is also working, and we shouldn't look at the glass only half empty. We should look at it as half full and be encouraged to continue those efforts.
And, you know, I would amplify what Louis said by making the point that I reflect on very frequently, which is that this pandemic will end eventually. And we will have to be able to work together as a healthcare community, especially in rural environments where literally everyone knows everyone. And I stay focused on that as well.
So we have just a minute to answer this question. I'm curious what somebody might think about, and it has to do with the environment that relates to shaming in the hospital itself and special privileges. So do all employees continue to wear masks and social distance so as not to single anyone out who hasn't vaccinated? I'm curious what the response to that is.
In my institution, it's a requirement. everyone has to still be masked.
And yet, OSHA just issued regulations that allow vaccinated employees to congregate without masks for meetings and meals. And literally, Ashley and I this afternoon were wrestling with how are we going to deal with that? And I don't have an answer.
And we've been meeting in small meetings as well. We now have a lanyard, like a special lanyard, that if you have a small meeting and everybody has a special lanyard at Maimonides, you don't need to mask anymore.
Really?
Yeah.
For our institution, we are still kind of navigating this and trying to find ways to do it that are still respectful, to say, essentially permit people the ability to say if they are or are not vaccinated, but not require it. And I think that that's really the tough line to walk, is going with the regulation, obviously, because nobody wants to go against that, but then also still respecting your workers, respecting the people around you, and giving them the opportunity to not do things that they're not comfortable with. It's a very fine line, especially right now. And I would never claim that anyone, especially our institution, will do this perfectly, but just keeping that in mind, I think, is the core thing that is holding our sanity together.
Yeah. So thank you all so much. This has been such a pleasure to participate in and listen to your thoughts and reflect on the last 7 months of vaccine rollout, and particularly a pleasure because I get to hear from different disciplines and really different viewpoints in different parts of the state. So thank you all for your participation, and have a good evening. I want to turn it over to Bob Klitzman to round things up.
Great. Well, thank you, Jenny, and thank you to all our panelists for really a wonderful discussion. I am Robert Klitzman. I direct the Masters of Bioethics program at Columbia, and I really want to thank all the panelists and also all of you who attended and asked questions, and also the media team and events team at Columbia. If you find these topics interesting, as I hope you do, please do check out, as Dr. Voigt said, the website of the Empire State Bioethics Consortium. That's empirebioethics.org. I should also say that if you go to our website, Columbia Bioethics, there's also a lot of videos of some of our prior events that you might find of interest. And last but not least, we have another event coming up that you might find of interest coming up in July on racing and needs to amplify diverse voices with Harriet Washington, who wrote a book, Medical Apartheid, and others, Joanne Suarez, who founded Latinx Bioethics. So we hope you join us for that event as well. Thank you all so much, and good night, everyone. Take care. Stay safe.